Hi everybody, thanks for joining. Couple of things. First, if you have any questions during the talk, feel free just to go ahead and ask. I want to be fairly informal. Secondly, the proceedings that you hopefully have or will receive are very detailed compared to what we're going to go over here, so you can use that as kind of referencing later on if you'd like. This is meant to be hopefully practical, clinical, things you can use, especially when it comes to this disease, but also client communication associated with this condition. So any questions, feel free to let me know. So just a little bit of background on me. I'm Dr.Shadi. I graduated from Cornell University in 2006, then did my one-year internship at Angel in Boston, followed by 2 one-year surgery internships at Long Island Veterinary Specialist. From there, I completed a 3-year small animal surgery residency from LIVS, then moved out west and became a boarded surgeon at the Las Vegas Specialty Center. And after that, I managed 3 facilities in Silicon Valley, being on call for all 3 24/7 for a year, followed by being part owner of a hospital in Los Angeles, where I was on call again 24/7, about a year and a half. And then after that, I started Vet Triage, which is my virtual platform for telehealth. Here's what we'll go through, rough outline. We'll define the disease, talk about pathophysiology behind it, how does GI disease play a role, clinical signs, diagnostics, medical management, a little bit of medical management. We won't go too in depth unless you want to, but obviously then surgical intervention, complications, outcome, prognosis, and then key points. Any questions you have, we can go over. So the first key point here is going to be client communication in terms of how to define this. So I tell pet owners, medically speaking, this is a primary versus a secondary condition. So you have primary factors for these dogs, primary diseases, and then you have secondary diseases to them that make up the entire syndrome. From a pet owner's point of view, I divide it into things I can fix and things that I can't fix, right? Maybe some of the things you can fix can make the irreparable stuff better, but I can't fix the irreparable stuff. And so that I find helps with their understanding of the disease, because this is obviously a multi-faceted problem. This is just a small list, by the way. I mentioned the most common stuff. There's a lot of things wrong with brachycephalics, as we know, and the more diagnostics you run on them, the more things you find. But we're going to talk about the major points of this disease. But for client communication purposes, things I can fix, things I can't fix, and that's how we're going to have to tackle this. So that way, their expectations are we're going to have a dog that's better after surgery, hopefully, fingers crossed, but not 100% normal. You still have a brachycephalic that has secondary issues that I can't change. And the reason why there's differentiation between primary, secondary, and fixable, not fixable is because some things that are primary can't be fixed, some that are secondary can't be fixed. It depends. But clients like to understand it from like, what can you do to help my dog out? So elongated soft palate, hypoplastic trachea, nasopharyngeal stenosis, stenotic nares, everted saccules, everted tonsils, laryngeal collapse. So for example, elongated soft palate tends to be a secondary condition, but it's fixable, right? And so this typically starts off with dogs that have stenotic nares, which is a primary condition. Because of stenotic nares, the airway resistance goes up in the nasal cavities, and over time creates a longer, thicker, soft palate. And so that's an example there of something. And so stenotic nares is primary, fixable. Elongated soft palate is a secondary change, it's fixable. But then something like hypoplastic trachea, it's a primary condition. They're born with a small trachea. Not really sure how to fix that one. I have had some surgeons use tracheal stents to try and fix these conditions, but this is not a dynamic process like collapsing trachea. This is just a smaller lumen trachea. So that, or it has redundant tissue in the dorsal aspect of the trachea, but regardless, that's a difficult thing to repair. And so all these conditions fall under those categories. And you're looking for any of these conditions. And of course, most pets have a combination of problems, of course. They don't usually just have one issue. So it starts off with stenotic nares, causes an increase in resistance in the airway in the nasal cavity, makes the palate get longer. As the palate gets longer, it causes a dynamic obstruction. Over time, this level of inflammation will cause the laryngeal cavity to collapse on itself, getting various degrees of laryngeal collapse. And from there, downstream, bronchiolar collapse as well, because of the chronic increase in the resistance. And so that's how you end up getting all these issues. Then when you have lower airway disease, that can turn into cor pulmonalis, so cardiac changes secondary to the increased pressures in the airway, all stemming from abnormal genetics, which we all know with brachycephalics. So here's a close-up of stenotic nares. This is just showing you the anatomy of the larynx, and over time, this will get inflamed and then start collapsing on itself. We'll go over the grades of laryngeal collapse in a little bit here. Here's an example of really swollen cartilages, arytenoid cartilages. And so they're enlarged, they're erythematous, and so this is from thought to be from constant physical contact with each other because of increased airway pressure from the stenotic nares. And so over time, they get more and more inflamed, which contributes to the airway obstruction that you see with these dogs. Here's another laryngeal view of a dog that's got classic everted saccules. So right behind the arytenoid cartilages, you have this, where this X is, these two sacs that will inflate and obstruct the cavity. This is, of course, a secondary change because of the increase in pressure. So the arytenoids here in the 0, over time, they start to collapse and contact each other, and then because of that pressure, the everted saccules start to become prominent as well. So this is a secondary change. This is actually fixable. In fact, over the years, I've gone away from removing these because I find that once I repair the nares and the palate, literally in surgery, they become less prominent. And so I've been leaving those behind. But I'm not sure they contribute that substantially to the upper airway obstruction anyway, compared to the nares and the palate and the laryngeal collapse. But just so you're aware, they do exist, and that's what they look like. Normally, you shouldn't see anything behind the arytenoids with normal respirations. When you dive into more advanced imaging, so this is a sagittal view on a computed tomography, so CAT scan, CT unit, and you're looking at comparing a normal skull-shaped dog with that of a brachycephalic. So you can see here, this is rostral, caudal, this is obviously the brain cavity here, and then the nasal region, nasal cavity leading into nasopharynx. In a normal dog, it's nice and spacious, has all these normal ethmoids and sinuses, and then in a brachycephalic, it's all collapsed and non-existent. So this contributes to the increase in airway resistance. This is a scoping. So in the choana of a normal dog, where these things are open, nasopharyngeal region, the right medial nasopharyngeal open area, left medial, and then here you have a dog with caudal, what is this? Abnormal turbinates. So you have this tissue buildup in the turbinates that should be just filled with air, and instead you have all this I don't know, the abnormalities in turbinates causes this thickness, and that of course contributes to the resistance. So these are other issues that you're not going to see normally unless you're performing a CT scan or scoping. And other than studies, very, very few studies that have looked at stenting these dogs' nasal regions, to me, they're otherwise irreparable, and it kind of come with the breed. Here's an insane view of our brachycephalics. There's just almost a vertical line here, and then you have a brachycephalic that's maybe not as severe as that pug, and then you've got a dog here that's got a little bit more of a muscle. So all these play a role, the anatomic differences. And then here's not a great view, but here's a radiograph, lateral radiograph of the dog. It's supposed to show you that the trachea is a bit more narrow than normal, and if you again, there's a lot of soft tissue superimposition here, but whether the trachea is more narrow because they're born with a smaller trachea, or whether there's redundant soft tissue over the dorsal after the trachea, I don't know. Both conditions are described, and we see it in brachycephalic dogs. So it just contributes to the increase in airway resistance. GI disease. So this is a fun one because it requires some investigation of the dog's history. And if a dog is coming to you in a respiratory crisis, you may not think of or have that information readily available as to whether or not this dog has had a history of GI disease. But more often than not, these dogs will have a chronic history of vomiting or not eating, something like that, regurgitation, some sort of chronic GI that fluctuates, comes and goes. The thought here is that these dogs, because of the pressures in the upper airway, alters the position of the stomach in relation to the diaphragm and the distal esophageal sphincter, and so you end up with basically hiatal hernias. There's 4 different grades of hernias, And because of the chronic herniation, these dogs get fluctuating intermittent GI signs. And is this a primary GI condition and the dog just happens to also be brachycephalic, or are these secondary changes from brachycephalic airway syndrome? I don't know. That's part of the discussion with clients. But hiatal hernia is only one aspect, one possible differential for GI disease with this syndrome. You also could have megaesophagus is possible, and if you have dogs that have either aerophagia or more often reflux esophagitis will cause inflammation of the upper esophagus, and you'll get this dilation to it, and it'll look like megaesophagus, but not the neuromuscular disease type, the esophagitis type, because of chronic reflux. And so that's also a possibility with these dogs. And then another brachycephalic issue, of course, is pyloric stenosis, right? So that can cause GI issues. Is that related to the disease of brachycephalic airway syndrome? Is that just because they are brachycephalics and they have this anyway? I don't know. And then, of course, with chronic aerophagia or acute aerophagia, you can have with gastric dilatation. Obviously, GDV is not something that we see that commonly with brachycephalic dogs, especially small breed brachycephalic specifically. But anyway, gastric bloat can result from aerophagia. And again, is that a secondary thing? It's aerophagia, probably. Or do they have some sort of GI motility issue unrelated to brachycephalic airway syndrome? The point is, investigate the history and figure out from the client, is this been a chronic recurring thing with the GI disease? And what if anything, will happen to the GI disease for that dog if I do fix the brachycephalic problems, and then go from there. And we'll dive into it a little bit later as well. But GI disease is an issue with these dogs. We do see it with this condition. Clinical signs, we're probably all familiar. How many folks here do see brachycephalic airway syndrome in their practices? Yeah, very common. How many of you first see it and talk about it at like the initial exam, whether it's a puppy or just first time you're meeting that adult dog? How many talk about it? Yeah, good number. Great, good. You want to talk to these pet owners before it becomes a crisis. As a surgeon, I typically don't get that luxury. I see them in a crisis or referred by the general practice to get this dog looked at and fixed. But if you can talk to them ahead of time, fantastic. So clinical signs, you get these loud dogs that are just snorting and open mouth breathing chronically, and of course they're brachycephalic, so not much to it with that. Obviously, if they're coming in some kind of shock, they'll look much different. They won't be stable, so they can come in lateral recumbent or sternal recumbency, difficulty breathing, upper airway obstruction, right? That's the emergency part of all this. Usually they're coming in snorting and being loud. Radiographs, so this is just to show you this, skull rats. Sometimes you can see the palate, and you're still going to do a sedated oral laryngeal exam. But if you're trying to figure things out and you're not ready yet to do that exam or whatever it is, maybe you're trying to avoid sedation for some reason, sometimes you can see an elongated soft palate on a lateral skull radiograph. This is a more scientific, objective way of figuring out whether or not the tracheal lumen is smaller than normal. I can't remember, I think it's the tracheal diameter and thoracic inlet diameter, I think. And if you measure these two, there's a ratio. I have it in your proceedings. I don't remember I don't calculate this because it's not a problem that I can fix. So I look and say, yeah, it looks like a small trachea, and that's where it ends for me. But if you want to actually measure it, you could, and the proceedings has your notes. And then finally, in regards to thoracic radiographs, there's several reasons to have thoracic radiographs. Number one is metastatic screening. If the dog is sufficient age, you want to make sure there's no cancer, sure, because they are coming with respiratory crisis. If they are coming in with respiratory crisis, you want to rule out all reasons for crises: pulmonary torsion, neoplasia, pneumonia, etc., foreign bodies, whatever. That's number one. Number two is bronchopneumonia is a problem. So you're looking at that classic cranioventral distribution, air bronchogram associated with pneumonia, pulmonary consolidation. So bronchopneumonia is the issue with these dogs. And then the secondary cardiac conditions that you can see. Anytime you have a acute upper airway obstruction, you are prone to non-cardiogenic pulmonary edema, and so that'll happen with dogs that have neck pull injuries, seizuring, electrocution, anything that causes upper airway. If it's really peracute, they're at risk of non-cardiogenic pulmonary edema. With chronic disease, cardiac With chronic airway disease, the cardiovascular system will be affected, so you're looking for cardiomegaly. Is there any evidence of pleural effusion? Hiatal hernia you're looking for in this region here. So there's a variety of reasons to have thoracic radiographs for staging purposes and to see where this pet is at, rule out other differentials. Ideally, you'd have at least 2 views, but 3 would be the best. Rather, ideal is 3, but if you can get 2, then you get 2, but 3 is the way to go. I don't run CTs on these dogs, but because it's in the literature, I want you to be aware that you can run a CAT scan on these dogs to look for those abnormal turbinates. So this is a pretty nice normal dog. This is one that's got some deviation here of the nasal septum. Here's a sagittal, again, a brachycephalic we showed before. It's just ways to stage these dogs further to let these owners know your dog has multiple issues, some that I can see with oral laryngeal exam, some I can see on radiograph, some I can see on CAT scan. But as everything else in the field, there's a grading system. So this is those caudal aberrant nasal turbinates. And if you run a CT scan on them on a cross-sectional view, you should be able to grade it if you do these. In a pet that's in a respiratory crisis, your primary goal, of course, is capture the airway and stabilize them hemodynamically, obviously. But when you have a stable patient and the means to do this, and you're going to do something about it, or at least educate the client, then I just want to let you know that there are studies out there on investigating these dogs further. But that is not routine for me anyway as a surgeon to CAT scan them. So I can't fix those problems, and but that's it. I can't fix them. Laryngoscopy. So the main point of laryngoscopy is not just to look at the anatomy, palate, tonsils, etc. It's also to intubate them, of course, but to look at the larynx. And you're looking for laryngeal collapse. And there's 3 stages of laryngeal collapse. Stage 1 involves just eversion of the saccules. So this is the laryngeal exam. Here behind the arytenoids, right? Behind the arytenoid cartilages, there are these 2 pink bubbles that pop up. Those are everted saccules. Then it can progress to stage 2, where the cuneiform process of the arytenoid contact each other. So the cuneiform, the front area here, will contact each other. They'll get all inflamed and pissed off, swollen and red like this with a constant contact. Stage 3 is progression of the arytenoids contacting each other with the corniculate process. So now both processes of the arytenoids are contacting, and you're getting a severe progression of the laryngeal collapse. And so obviously this is a progression sort of thing. Prognosis, of course, follows this. The earlier you can catch them in the laryngeal collapse phase is the better, obviously, because it's more likely to be reversible if you fix the primary stuff. You can't fix laryngeal collapse, but if you can eliminate the primary causes of it, and in an early enough stage, you hope that these things will reverse over time, or at least improve clinically over time. Now, when I say that there's no surgical option for laryngeal collapse, it's not entirely true. I've had surgeons, and I've done this as well. We've done partial arytenoidectomies, we've done laryngeal tieback surgery. There are things you can do, but these are band-aid efforts for a pretty crappy condition. So it's not great, and usually you hope it improves with repair of the primary conditions. If you're lucky enough to have an internist and they're scoping the airway, then this is just further investigation to see if they have any abnormalities in their lower airway. For me, as a surgeon, it's more of looking on radiographs to see, do I have to be concerned about lower airway disease? Like, can I see that bronchioles are collapsed? And I can talk to the owner about it. But again, these are secondary changes that I'm not going to do much about as a surgeon, but they are important for staging purposes. So you have the luxury of somebody who can scope, and you're trying to rule out other things as well, then that scoping is also something that's reported. Okay? Any questions so far about any of this stuff? So now with medical management. So from my point of view, medical management is surrounding the capturing of the airway and stabilizing the patient. Because I usually see them in a crisis, and I'm trying to stabilize them while performing my laryngoscopy to confirm the condition or conditions. And then I'm talking to the pet owner about what I want to do next, the blood work, the radiographs. And then from there, if everything looks good on those diagnostics, meaning no surprises, then can I go ahead and repair this dog at the same time? So they're coming to me in collapse, in respiratory compromise. I'm trying to stabilize them, diagnose the problem, get permission to repair the dog all in the same sitting. Because I have to sedate them for the oral laryngeal exam anyway, and usually have to sedate them to kind of capture their airway. So that's my goal of medical management. However, in clinical practice, you may be inviting the idea of this syndrome to pet owners and saying, your dog may benefit from surgery now or later. In the meantime, here's what we can do to palliate this at home for the dog to prevent a crisis and to give you time as a pet owner to think about what you want to do, because your 3-month-old bulldog is already loud and the nares are closed and everything else. So you may want to consider this, but in the meantime, we can do some medical management. So that's more controlled home setting. So anyway, so for the acute dog, you're looking at various ways of supplementing oxygen. These are all different modalities you can do. Probably the most efficacious is going to be some kind of nasal O2. So you're passing a nasal O2 cannula into the dogs. I've used this in combination with oxygen tanks. And if you don't have accessibility to one, maybe you have access to the other. Otherwise, there are other things you can do with these dogs to try and help. But whatever you can do to supplement oxygen is what they need, of course. Then you've got a myriad of medications you can give them, all kinds of stuff you can do. And so this kind of depends on what your experience is and the individual case. If you're trying to capture the airway, you're going to probably sedate the dog with something. And so whatever modality you want to use, this is terrible imaging. So torb here, H-promazine. I don't know what that says. What is that? Oh, propofol. Yep, propofol. So the thing with these diagnostics, these sedation drugs, not as important with this condition necessarily because in laryngeal paralysis it's dynamic, and so you don't want them to sedate, or else it'll look like paralysis or paresis. You're not sure. So with these dogs, I do try to titrate a sedative like propofol to effect while I'm looking at the airway. I'm looking at the movement of the arytenoids, I'm looking at the palate, looking at the saccules, while the technician is slowly giving propofol so we can get this dog sedate enough that I can then pass a tube. So that's how I'm looking at the airway while trying to sedate the pet for therapeutic reasons and diagnostic reasons. So I want to see the movement, but it's not as crucial here. If you need to just capture that airway, sedate that dog, go for it, and it's sufficiently enough to pass a tube, and then attach them to oxygen, and then go from there. Steroids, depending on what generation you're a vet, steroids are either awesome or the devil. Just depends on how you were taught. I'm a fan of steroids. I think that they're really good, especially in the acute perioperative period. If I'm trying to decrease the swelling from laryngeal edema, from laryngeal collapse, I think it's really good for these dogs, but it depends on the individual case. If they already have shock gut from being destabilized, then I get a bit more concerned about giving steroids when they already have like hematochezia from being in shock, so I'll try to avoid it. You already have a risk there of bacterial translocation from the GI tract, and steroids, of course, are going to agitate that further. But in general, for your straightforward kind of perioperative period, we tend to give steroids to lessen the swelling. And this helps, theoretically, will help with post-operative recovery. If you're doing something in the mouth, let's say removing the palate, that inflammation there can contribute to swelling as well. Steroids can help minimize that risk for post-operative. I want these dogs to be awake and alert after surgery. So steroids, depending on what your thoughts are on that. And then here's your typical brachycephalic that came in a crisis, capture the airway, you've got a catheter in, we're checking blood pressures, they're attached to oxygen, maybe gas, depending on the patient. Otherwise, you've got maybe a propofol CRI going or intermittent boluses, whatever you want to use to achieve the goal. I'm a bit old school, I guess. I'm not sure how many people use Cerenia, but they use it frequently. But in terms of the perioperative period, like as part of a pre-med, I know a lot of people now use Cerenia as their cocktail. So great, good. If that helps, fantastic. Obviously, aspiration from these dogs, because they have a history of GI issues, is a problem. So I'm all for this. I'm more of a Reglan guy myself. Not that the two are comparable. They are not. They're two different drugs. But I actually tend to give these dogs a bolus of Reglan at induction to help get the GI tract going. And then if needed, depending on the case, they're on a Reglan CRI or IV TID dosing, but I like the CRI more, so if I can do that. But it depends on the case. So for example, if if this dog comes into me brachycephalic in a crisis, and I'm staging him with radiographs, and I see a stomach full of food on the radiographs, I like to give them Reglan and keep them on it to get that food digested quicker, get it passing along, because I'm trying to minimize risk of regurgitation and vomiting intra-op, post-op for these dogs. So, and then of course some of these dogs do have sliding hiatal hernias, so that helps with that as well. So I'm a fan of Reglan. Oh, here it is, metoclopramide. But you can try what you want, see how things work. I don't really see a downside to it. To me, it helps. And of course, you can use both. The reason why I have Convenia and Simplicef up here, so straightforward brachycephalic disease with no comorbidities, they're not getting antibiotics. Maybe they're getting 1 dose of Sevacilin IV during the procedure, and that's about it. The surgeries are very fast, and they're not under very long. And unless I have evidence of like bronchopneumonia or something like that, I'm not going to have my antibiotics after surgery. It's most of the surgery between the nares and the oral stuff, it's all dirty surgery anyway. It's not sterile. So antibiotics for me, I'm not really going to do it. But if you did want to, I do like Convenia. Not that it's labeled for this indication, but these dogs are already prone to having GI issues. They may already have GI issues from the brachycephalic syndrome. If I can minimize oral drugs at home for ease of the pet owner, but also to minimize too many drugs in this dog's GI tract, and I give them an injection of something that will offer some coverage for 10 or 14 days, I'm a fan of this. The same way I'm a fan of Simplicef, because it's a once-a-day drug. So if I'm not going to give Convenia, then I can go with Simplicef and give that once a day. So at least it minimizes the antibiotic exposure for that dog and the complication of GI upset from antimicrobial use. And I did mention things like, maybe I do later, I don't remember, but things like trazodone, gabapentin, tramadol, things to calm down the dogs, especially if they're a bit more OCD, a bit more anxious. Things like keeping their temperature cool at home, avoiding excessive walks when it's hot and humid out. These are all kind of common sense things to try and medically manage these dogs at home. How many folks here have performed a temporary or permanent tracheostomy? Yeah, so it's a cool way of bypassing the upper airway for these dogs, especially if you're having a lot of difficulty trying to intubate them. It's just too swollen and collapsed in there. Then it is an option to try and bypass it. My suggestion, if you're going to dive into this world, if you feel like you see enough cases that may have warranted this in the past, then maybe try it on cadavers first. It is a fairly straightforward procedure, but you want to make sure you have the right equipment for the tubing and stuff. So not a bad deal. I'm again performing temporary ones way more often than permanent ones, and the temporary ones were literally for perioperative capturing of the airway, because for some reason they couldn't enter with a normal endotracheal tube. And so then while they're healing post-op, you try to get them off of this as they get more and more awake. Permanent trachs, the one that I have seen, are always a management nightmare for a permanent trach, because they're always these large, fat, old bulldogs that have mucus plugs constantly, and it's back and forth from the ER all the time. But permanent trachs have their own indications for them. Now surgery. So a couple things here then. So first off, the nares. There are different techniques with the nasal sacculectomy, and however it is you want to do it is fine. I mean, the goal here is to open up the nasal, the nares sufficiently enough, and try to have it as symmetric as possible for cosmetic purposes. But you're trying to increase the airway. You want to, when you make the incision here, you're trying to get some depth here to the cartilage. You don't want it to be too superficial when you open these things up. So the way I do these is I do a pizza pie shape, so it's like this, and then that way when I size that part out, reoppose it, and then you have an opened airway. And almost always I'll end up doing the left side first. I do the right side, and it looks way better than the left. I go back and redo the left side. Almost always, it's like, but so if you're not sure if you're gonna like it, maybe put only a suture or two here just to stop the bleeding, and then you can go to the other side, fix that, and then say, okay, do I like this? And then if I do, I'll add more suture. If not, I'm gonna remove the suture and cut a little bit more to make it a bit wider. There's no rule, for this. I mean, these dogs, don't have normal nares anyway, even with surgery, but this is you can see the marked difference in there. And this small fix, it improves their resistance dramatically in the nasal cavity and downstream. So as far as bleeding goes with it, because they will bleed, I don't have an easy way of doing it other than either maybe you're lucky enough to have somebody who can kind of dab for you while you're trying to do stuff, or just hurry up and just do it, because it's not life-threatening hemorrhage, right? But it's annoying. It gets in your way and you can't really see where you're placing your sutures. Yeah, but I don't have a better way of doing it. Nothing really works in my hands for stopping the bleeding. Just get the surgery done, and just by contact, it stops bleeding. I use usually I'm using monocryl here because I'm not going to remove them. I'm just going to have them fall out over time. This is so first repair the nares. Dog is intubated on sternal recumbency. Then we reposition. So they're still sternal, but we're changing the position of the oral cavity. So now we're opening up the mouth by whatever contraption you want to use. It's always some ghetto thing with gauze and vet wrap and 2 IV poles that are collapsing on each other. Whatever. Figure out a way to do it and have the airway open. And now, here's the finished product with the nares. Okay. So anyway, so now you're ready to operate here. There's a few things that are, of course, in your way. Number one is a brachycephalic mouth. It's always like compact in there. And then you've got a pulse ox in there, you've got an endotracheal tube in there, there's gauze that's in your way, so everything's in your way to try and fix the palate. So we'll go over kind of how to contend with that. Let me see. Okay, so a couple of points with the staphylectomy. So if you want to know how much to remove of the palate, right? You want the palate to end up where the tip of the epiglottis is like just barely touching your new palate. That's the way. And that is, of course, very dynamic, because if you alter the anatomy of the oral cavity, you're moving the tongue this way, that way, they've got an endotracheal tube there, it's changing the positioning of the palate relative to the epiglottis. So you want the positioning right before you make your cut to be as neutral as possible when you plan this, which means ideally you have nothing in the trachea, nothing on the tongue, no one's retracting anything. The dog is there in sternal recumbency, and you have the mouth open just enough to look and say, okay, where am I planning my cut? And you guesstimate where you're going to make your cut based on that neutral position. So during this time, the dog's airway is not captured, right? And so you need to evaluate this fairly quickly before the dog starts to wake up on you. Or you can have somebody titrating propofol if you want, IV, if you have that capability, or some sort of anesthetic like that, sedative like that. Anyway, in order for you to adequately figure out where you want to make this cut, so here it is in relation to the epiglottis here, you want to make sure that all of your retraction tools, everything is kind of out of the way so that the anatomy is not deformed or altered enough where it's going to skew how much you cut. And you prefer to not cut too much. You'd rather leave some behind if you're being cautious about it rather than the reverse. Because the reverse is detrimental. We can't really fix that. And now you have a dog with chronic nasal discharge and recurrent pneumonia because you transected the palate too short. So you prefer to have it a little bit on the longer side if you need to, and you could always retrim later on if the client's complaining about recurrence. But neutral position, plan out your cut. And this looks, this drawing's a bit dramatic. I would say it's probably too much. But either way, you now have a transected palate. How you want to do this portion of it? So once you've aimed it, you know where you want to cut. Then you can re-intubate the dog, and then you can take your time with the actual cut. But for that planning purposes, you want to try and have it where it's neutral as possible. So then as far as this part goes, I think I've done maybe 2 with suture. I've done all of mine with a ligature device, a bipolar sealing device. I love ligatures so much. Anything that's got a pedicle, I'm using it on. I've used it on neuters, like dog neuters before. Like it's so easy, it's so quick. I can avoid suturing, it's a bit faster. And if you talk about a splenectomy, that takes a splenectomy from like a 40-minute to an hour procedure down to like 10 minutes, 20 minutes. Like that's like open to close. And the hemoabdomen that I'm trying to hurry and get this dog off the table, this thing, it's like Pac-Man. You just go through the pedicles and just cauterize and cut as you go. And there's different sizes, and I don't know what the current market is with this. Like, if I heard at one point they stopped selling them, stopped making them. But there's different sizes. They have a small one. This is a small one that you can use to instead of doing the suture, which can be kind of annoying. You're working in a small cavity. It's bleeding, of course. you can instead just clamp and cauterize and cut as you go, like Pac-Man. It does cause thermal damage. There will be collateral damage to the tissues there. You also want to make sure that you don't touch the palatopharyngeal arches on the side, right? You're trying to minimize trauma because this thing is a very powerful thermal device. So it's gonna create some thermal necrosis on the sides here, but it is phenomenal for anesthetic time. And I have way less dogs post-op that need to be kept under because they keep waking up in a crisis because of all the swelling. Even though this thing does cause thermal collateral damage, it's phenomenal for it. Yes? Ligature, Ligasure. Ligature. At least that was the old device. I don't know what they have now to replace it if there's new stuff out there, but I'm a huge fan of it. So then what I also do as part of my regimen is once I transect the palate, during recovery with the technician, I have an ice cube with gauze wrapped. I attach Alice tissue forceps to it, and I do have them ice pack the palate for no more than 10 minutes while the dog is recovering. So it helps the inflammation there. They've received steroids as well to help with the inflammation, and we have an ice cube and a gauze that's there for no more than 10 minutes to help with the swelling. I mean, it works really, really well. But of course, if you've been doing this for a long time, you're probably proficient with this technique, and that's great too. That's great. I got spoiled. I started using ligature. How many folks here perform any of these surgeries, like any combination of these? Practice. Nice. Yeah, good number. Good. I had mentioned earlier about the everted saccules. So this is the larynx, and you have these saccules behind the arytenoid cartilages. You know, whether you transect them or not. I'm starting to stray away from this, but whatever. And so most of the time, if you read the books, they'll say just mets and bombs, but I do find that they bleed. So if I have a monopolar cautery, or the ligature can fit back there, but usually it's too big, then I'll try to cauterize these off instead. But otherwise, you can transect it and either compress on there to stop the bleeding or just let it stop on its own. But I always get nervous with the blood because blood itself is going to cause issues with the airway, and it's a great medium for bacteria to grow, and so blood is entering the lower airway, pneumonia, so I get nervous about it. But anyway, that's an option. And then this is a picture of a partial arytenoidectomy. So I can't tell too much here because it's kind of a mess, but there's the transected palate, and then the arytenoids here, you can see how sharply edged they are. You can do that as a salvage procedure. I do not recommend it unless you really have no other choice, meaning you fix all the fixable stuff. The dog has bad laryngeal collapse. You tell the pet owner, look, the collapse is terrible for this dog. We're going to see how we do tonight, wake him up. We may have to go back in and do something dramatic with the larynx if this dog can't get under control. So that's either going to be temporary tracheostomy tube, partial arytenoidectomy, laryngeal tieback, a combination of things, just depends. And the owner has to understand these are reported but unconventional measures to try and handle collapsing trachea. But it's either that or death, so you can pick your poison. By the way, the reason why I'm being a downer when it comes to all the arytenoid surgeries I mentioned is because if you create a permanent opening in the laryngeal aperture, you're more likely to get aspiration pneumonia. That's why. So there's no more protective measures for the dog. This is just to reintroduce the idea of tracheal stenting for dogs that have hypoplastic trachea, not collapsing trachea, different disease, hypoplastic trachea. Sure, if you have the ability to do it and a pet that you think you've fixed all you can fix, then it may be an option there. I don't know what the current studies are on this, but it is an option. This is the laryngeal tieback surgery for those who have not done it before or not seen it. A suture is placed behind the thyroid cartilage and the arytenoid, the cricoid cartilage and the arytenoid, and it's sutured tight to open up the arytenoids more. So this is just an intra-op view of the meaty mess you get when you try to do it at the tieback. But and again, I'm not encouraging these surgeries for laryngeal collapse. I'm just saying that it's a salvage procedure and a dog that really needs it, and a client who understands, these are potentially options. Okay, complications, pneumonia, we talked about many times here, needing an emergency temporary trach because the dog has so much swelling or collapse that they can't get any airway movement, so you need a trach. This is a really screwed up laryngeal collapse. You can see, these arytenoids are just hugging each other. They're just like yin and yang, and there's no way, there's no airway coming through here. So Anyway, just to show you, and all the swelling that's there, all that laryngeal edema. All right, outcome. Improvement, vast majority of cases. Mortality, very low. Recovery, considered excellent 6 months post-op in 65% of dogs. Post-op, 6-month recovery being good, 25%. So right off the bat, the vast majority are good to excellent. 1 year excellent, 50%. 1 year moderate, 50%. 1 year post-op, poor, 2%. So pretty good there, despite all the scary things we spoke about. Prognostic factors in literature, if you can get them earlier, great. There was a study that looked at doing like a punch biopsy for stenotic nares in dogs. How old were they? 6 weeks or 8 weeks, really young, and these dogs did not develop brachycephalic syndrome after that. If you can get rid of the initial insult, which is the nares, then early enough. Now, I don't necessarily know that I'm advocating yet for that young of a surgery, just saying that if you can catch them early, better prognosis for the pet. Younger dogs, of course, have better prognosis because older dogs tend to have comorbidities, plus you catch them younger, they have less secondary sequelae to this disease. The degree of laryngeal collapse plays a role. Obviously, the more mild, the better. The presence of hypoplastic trachea hurts their prognosis, no surprise there. And the presence of GI disease does hurt their prognosis, which is why I want you to investigate the history further and try and tackle the GI part of this condition as well. And finally, key points. Client communication is key, talking about primary versus secondary, or ideally repairable versus non-repairable aspects of this disease. Keeping in mind the GI clinical signs. So as far, we didn't talk too much about like treatment for these guys other than the perioperative period with Cerenia reglan, but I do put these dogs that have GI disease on a long course of, usually omeprazole is what I'm going with, over Pepcid, not for any reason other than just how I was trained with it, but whatever, any antacid is good. And I usually tell pet owners, look, you've told me that this dog has an entire history of GI issues, why don't we do a month's worth of antacid and see what happens? And if you're happy with it, great. If you're still not seeing much of a difference, then maybe we need internal medicine workup or something and turf them, someone else. But otherwise, if they're seeing a good response, then we can have them on antacids perpetually. Tailor the surgical repair to the case at hand. Yeah, of course, yeah. I don't know why it's even in there, statement. Yeah, and that's my talk. If you have any questions at all, feel free to reach out to me, all the social media stuff and email, and I'll take any questions you have. Yes?
Can you talk about alar vestibuloplasty?
Alar vestibuloplasty. So I remember it from my surgery boards, and that's a, yeah.
Because this week I did a stenotic nares repair, and then I know there's some people who do it more lateral versus just closer to the opening, and then I posted on one of those Vet Hive or something like that, and people were like, you really should be doing alar vestibuloplasty. They said like you're not helping much if you just did that. So then I looked up a YouTube video, and they took out like a whole chunk of tissue. I was really scared, so I didn't do that. But I thought if somebody could talk about it.
Because I'm familiar with the terminology for it, but so their argument is that the amount of tissue that's being removed with these wedge procedures is not sufficient.
Right. So they went like behind. They just went in and grabbed something and just like stabbed and cut and pulled out a whole bunch of tissue.
Does anybody have experience with that?
I've heard the same thing.
You've heard the same thing?
Yeah.
What's that?
I said, why don't we just, if that's the case, do the wedge procedure and then do rhinoscopy and just look at it?
Oh, with the scope of the rhinoscopy? Yeah, that I don't know either. I don't know. I myself never perform rhinoscopies. I'm not sure how the visualization would be, but if
Because if you're just going in there and stabbing, put a scope up there, please.
Yeah. So yeah, you could. I've never had indication for it, but obviously if you don't investigate, you don't know. So if you have abilities like that, but yeah, other than reading it for like surgery boards, I don't have any experience with it. My goal has always been make it cosmetic and open it enough to get the job done, and they do fairly well with the wedge technique. But I'm all for other stuff if it's better. I just don't know. I also wonder if you look at PubMed, whether there's some literature on it. Maybe there's like a larger case study on it, you know. So PubMed might be a good place to search too. Yes?
I have a colleague that does the ALAR, and she really enjoys it. And the way that she does it is she grabs kind of the most medial aspect of the lateral ridge, I guess. She takes an 11 blade and goes straight in at the top of the nasal opening and just kind of shaves towards, I guess, the 4 o'clock. And she takes out that whole medial aspect of where you're doing your wedge, essentially. But she also gets like almost a piece of the internal turbinate. And she has, cosmetically, they look similar after the first 6 months.
Mm-hmm.
And she has said that she likes it.
Nice. Maybe what I'll do because I give talk a lot, maybe I'll look into it further and then I can add to my future talks and see. Yeah.
And essentially, like, it's kind of like because I do the wedge.
Yeah.
And it's essentially like the wedge where the bleeding just kind of, it sucks at first and then just stops.
Yeah.
And they do fine.
So they don't suture.
She doesn't
The video
suture anything.
cuts off, like,
She just
after
grabs it,
you
goes,
start.
done.
Oh, there's no suturing.
There's no suturing. They just put like a huge, like a Q-tip in there to block it for a little bit.
I mean, that makes sense. I mean, that makes sense.
I found 2 YouTube clips.
Oh, okay.
Very alarming to look at.
Okay. I'll have to look at it further and see from there. Yeah. Any other questions? Yes?
What age do you recommend the nares surgery? Like, is it okay to do it with a neuter, or should I be doing them sooner?
Yeah, so the question is what age you recommend, like should we do it at the time of like spay or neuter? I would love to see it at spay or neuter. I think that'd be great. But I don't have anything to back that up. Because as a surgeon, I see a biased population of really screwed up old dogs that come to me for this problem, you know? So, but I would love to see that, and it'd be great if we had a paper that looked at that as well, because it's just like, you know, us performing a gastropexy prophylactically, right? Like we're doing that anyway as a preventative measure. Why not consider the airway disease for the dogs in this signalment? I'd love that, but I don't know if I can recommend it, I guess, because you know I'm backing up with literature. But it'd be great if you want to take that on for the right client, you know. I want to say maybe the youngest I've done it is like a year of age for a really gung-ho client that the GP talked to them about it. They want to consider it. They move to the surgeon. I go over the thing, and then they did it. But yeah, I have a very biased population, but I'd love to see that. I can't imagine it'd be detrimental because that's that one study that it's in the proceedings. I can't remember how old those dogs were. They were very young. And according to that one procedure, small study, I think maybe 12 or 15 dogs, they did well. So we need larger studies to look at that. Yeah. Yes?
How do you feel about a soft palate resection being done in GP without access like laser or lasers?
So how do you feel about GPs performing the elongated soft palate without access to the more fancy tools? I'm all for it. We know how hard it is to access care these days, especially with specialists. They're backed up for weeks or months, and sometimes these pets can't wait that long. And if you have a client who understands, like, hey doc, I know there's a fancy place downtown, but they're booked out for weeks or months, or they're beyond my budget, can you do it? And you talk about pros and cons and everything else with a possibility that may have to be transferred over to ER if things don't work out well post-op. I'm all for it. I think these are procedures that you can do because, like I said, the more advanced diagnostics you don't really need. It's nice to have the scoping and the 3D imaging. You don't need that stuff. Radiographs, blood work, and then cut. So yeah, I'm all for it. Just like any other procedure, I'd recommend if you have the ability for a cadaver practicing for them, especially with the palate, that's a good idea. But otherwise, yeah, I'm all for it. I don't. Except for some procedures, you know, there's some procedures where it's like this, a surgeon should do this, you know, like a hemilaminectomy or a thoracotomy or something, probably ought to not be in a GP. You need a whole bunch of stuff for that, you know, and the monitoring post-op and all that. But a lot of these procedures, I'm a huge fan of them being done in GP, yeah.
Do you think that they need specialized care post-op and that, you know, there's a chance things are really gonna go south?
So the question is, do you think they need specialized care post-op, especially if there's a chance things might go south? It's always about client communication. So the client understands you're going to get the ivory tower gold standard at the specialty hospital. If that's not an option for you, we can do a great job here. It's not going to match up with that, but we can do stuff here. And I, as a doctor, feel comfortable with that, but are you comfortable with that, Ms. Jones? And then you let them decide. But monitoring post-op for these, you're looking at really someone to monitor the basic vitals and then pulse oximetry. Beyond that, I guess blood pressure is always nice if they do go into some sort of crisis. But beyond that, I'm not sure what else you would need. Oxygen is the big one. And if you have oxygen, great. If not, it may be a bit more hairy for you there. But again, if things go south to that degree, do you have access to a 24-hour facility who can take on that case afterwards at night, or for the weekend or whatever it is? And is the owner willing to do that if that does happen? Because now you may have saved them the cost of the surgery, then that's all going to the ER afterwards. So, yeah. But I don't think anything too fancy as far as diagnostics go. Most people have a pulse ox and blood pressure monitoring, and then oxygen therapy. Yes?
A spay is much more complicated than either one of these procedures.
Say it again?
I said a spay is harder to do than either one of these procedures.
Mm-hmm. Yeah.
And we do the nares every time we spay.
You do? Yeah. So he says that he does the nares every time they spay. And so I assume long term you're finding good results.
We've been doing like 5 years.
5 years. Yeah, that's great. Yeah, it's funny how spay is so routine, but it's abdominal surgery, it's vascular surgery, and yet this is something that we're terrified to do. So it's interesting. Yes?
I would just share that we see a lot of Boston Terrier puppies and little Brachycephalics. When they're 4 and 6 weeks and we can see their nose is kind of squished, we trim them right then.
Mm-hmm.
And it seems to do it for most of them.
What technique do you use for?
Cut it off horizontally and just cauterize it with some silver nitrate. And grow up, they look great and they do well.
There you
I
go.
mean, they're immediately better.
Yeah.
And the way we know for sure to do it, they're the ones that are blowing bubbles when you see them. When they're blowing bubbles, those are the ones that fix right then. You just mask them down by ISO, turn them, done.
I love it. I like that. Yes?
How would you transfer those to an ER?
ER?
Yeah.
So I've seen things transferred to me with full-on IV poles and a CRI of Valium going in, and the pet owner's like, here I am, and I have all this, I've had some owners that are bolusing Valium in the car IV on the way to the hospital, so whatever it takes, I guess, Ideally, you want to send them as stable as possible, but that depends. I don't have a good answer for that. It's arm the client with whatever and say, I'm trusting you with these narcotics and IV access, and get to the hospital safely. And then you call ahead and say, hey guys, I'm sending you over this mess. It's gonna come into you on IV pole and whatever, and you go. But yeah, I've had dogs that come in with just their abdomen closed with just towel clamps because they didn't explore. The liver mass they thought it was a spleen. It was a liver mass. They can't remove it. Clamp, send them on over, and here they are. How do they not get septic abdomen? I have no idea. But the animals are so resilient. But anyway, I've had some pretty crazy transfers to me. Yeah, yes.
So in those cases, not from a non-surgical perspective, I'm thinking more of an ER perspective. Once we start to see so much of that edema, we had there was a local hospital nearby that ended up having a brachycephalic, jerk Frenchie that came in for just a routine exam and vaccines, ended up just freaking out and died, just died. And they could not place any T-tube, they couldn't do it because there was so much edema and swelling. If we get those kids over the ER was too far away, but if we could, at that point, is it I keep hearing it's just done deal. What's your success rate?
You're hoping that in a scenario like that where they're just completely closed off, swollen, whatever it is, what you're hoping to do in an emergency setting is obviously capture the airway. If you can't pass a tube, then it's a temporary trach. Is what you'll end up needing for that. And then you want to get the swelling down. That's where steroids come into play. Give them a round of steroids. I give them about 20-30 minutes after I give steroids IV, and if I'm not happy with it, I'll repeat it again. Because again, in a crisis scenario, I'm doing that. You want to get the swelling enough to where this pet can stabilize, and then from there, what's the permanent fix here long term? Because if this dog just wakes up and does the same thing again, we didn't accomplish anything. So are there things that we can fix once the swelling comes down with the steroids? and you capture the airway, hopefully, then you see, okay, what can I do here from that? But yeah, the ones that come in a mess, they can be salvaged. They can be salvaged, but it's all times of the essence. You have to act quickly. You have to be comfortable with septic cases. And by the way, at the same time, we didn't talk about like fluid resuscitation. Monitoring their temperature. Are they hyperthermic, hypothermic? Are you bolusing fluids? How much? Can you put in 2 catheters? Do they need head starch or something? Are they not responding? Are their blood pressures too low? These are all things, standard ER stuff for anything in shock. So yeah, it sucks. That's why the benefit of cutting them early is so good, because you want to avoid this crap. It's better for the animal to intervene early enough. Yeah. And then don't forget things like weight loss and keep them out of the heat and the humidity. Having them just lifestyle changes like that, I guess, too. Anything else? All right, thanks everybody. Appreciate all the questions. Thank you.